So that's what our agenda is. So coming to the initial presentation, like our agenda goes for today is levels of sleep study. What is level 1, 2, 3, and 4? Leads in each in level 1 polysomnography. How to understand 1020 system and how do we connect? And then we'll go to the live demo of today's patient. So coming to the basics, what are the levels of sleep studies? There are 4 levels of sleep studies. That is level 1, which is the topmost priority because it has all the senses that is required to monitor sleep. Level 2 is just one step below where there is no video recording or there is no person present during the sleep study. Level 3 is also called respiratory polygraphy, where we have only senses monitored for respiratory events. Level 4 would be a home testing where there are only 1 to 2 senses. Whereas in level 1, as you can see, it is usually done as an in-lab study. The sensors which are used to monitor sleep are all EEG, ECG, EMG, and EOG. EOG is for electrocardiogram eye movements. EMG is for electromyogram for muscle activity. Oxygen saturation, respiratory effort. ECG also is most important, and the other position sensors, snore sensors are also added as in level 1. So level 2, the only difference between level 1 and level 2 is there is no person monitoring it or there is no continuous video audio recording. So it can be either done in a lab or it can be done even in homes. So the number of sensors is slightly less where I told about no audio or video recording and there is no person present during the sleep study. Level 3, the 4 sensors which you should always remember is about airflow, where it could be thermistor and nasal cannula, oxygen saturation, and respiratory effort belts, which is also called RIP belts, thorax and abdomen belt, and then SpO2 sensor along with pulse rate. So level 4 could be one level down where there could be lesser sensors like an oxygen saturation or a nasal cannula flow sensor along with respiratory effort belts. So these are the levels of sleep studies. So when you learn level 1, so 2 and 3 and 4 comes along its way. You don't need to learn separately 2, 3 and 4 because it is just some of the sensors are not connected. So coming to the 1020 system. So some of you might have seen EEG people connecting EEG to patients to monitor their seizure activity, which is slightly different from this system. This 1020 system is acknowledged by AASM, American Academy of Sleep Medicine, which is very useful in polysomnographies. You don't need to connect all the sensors as in EEG monitoring for seizures because you are not worried about which area is throwing seizure activity. Here we just need to have the 1020 system to know what stage the patient is sleeping on. So why it is called 1020 is because, as you can see here, all the numbers shown as percentages of the distances measured are all either 10% or 20% in both recommended as well as in acceptable connections. So forget about this acceptable connection. Acceptable is something like when you're not able to do the recommended one, you can do it as an acceptable one, as every connections in AASM manual will have both recommended and acceptable. So always try to do the recommended connections. So coming to this, you should always know it is between 10 and 20% is the distances between the landmarks or the points at which you connect. So here some of the basics are, as you can see on the left side of whatever left side of the central line is all in odd numbers like 3, 3, 3, 1, 1. Whereas on the right side of the central line will always be in even numbers, either 4 or 2. Okay, so the most prominent point just below forehead is the Nacian, and inian is the posterior most occipital protuberance, which is called inian. Okay, so the conventions are F is for frontal, C is for central, O is for occipital, and M is for mastoid 1 and 2, which is the reference points. Just touching the basics, any voltage potential that should be measured should be compared with the baseline. Here, the reference leads are all mastoid, which doesn't show any EEG activity. So frontal, central, and O1 are all reference to mastoids. So in detail about this, so the most important points which you should know as a landmark for connecting 1020 system are Nacian, inian. So as I said, Nacian is the most prominent part just below the forehead, and inian is the occipital protuberance or the most prominent point in the posterior occiput. Preauricular point is this one, which is the reference for measuring on either sides, and this is the mastoid process. So as you can see here, from Nasion to the first reference point, that is frontopolar 1, is 10%. And another convention which you should remember is all the central points are with the suffix Z here. As you can see, it's either FZ, CZ, PZ. OZ is not seen here because we are not worried about OZ, as well as FP1 is on the left side of the patient, left side of the central line, whereas FPZ would be in the central line. So we'll discuss in detail about how to connect and what are the steps of connecting 1020. So next comes the EOG, where you can see the outer canthus is the reference point on either side. It is 1 centimeter from the outer canthus lateral as well as above on one side, which is E2, that is on the right side, and 1 centimeter lateral and below on the left side, which is E1. Again, the convention is left side are all odd numbers, right side are all even numbers. So why is it connected one below and one above is to measure the conjugate moments. When the eyeball moves up, this one will measure the potential which is increased because it is moving towards this lead, whereas the eye again moving upward is like opposite to E only, which will be scored as negative. To measure conjugate moments, you connect on either side, either up on one side and down on the other side. So coming to the chin leads, which measures EMG, which is also called chin EMG. The central point is just 1 centimeter above the inferior edge of the mandible in the central midline. 1 centimeter above is the reference point, which is called chin Z. And on left side is chin 1 and right side is chin 2, which is 2 centimeter from the midline, 2 centimeter from the inferior border of the mandible. So why do we connect two sides? Even if one gets disconnected, the other will be able to record. Same way for EG, why do you connect on either side is you just need 3 leads on one side is itself enough to stage the sleep. But you have the other 3 leads as backup leads, where if one of the lead gets disconnected, the other one can pick up EEG waves. So this is the leg EMG, where the electrodes are placed on the anterior tibialis muscle. You have to monitor the leg movements by moving your dorsiflexing your ankle so that the anterior tibialis muscle becomes prominent. So chest leads, lead 2 is placed as given here, one in the apex of the heart, the other on the right side just below the clavicle. So now how to connect steps of 10-20. This comes only with practice. There is no shortcuts to it, but you need to understand the basics of it to start connecting on a patient. So as I said earlier, the landmarks which you should be very clear about is the nasion, that is the prominent just below forehead, the inion, that is occipital protuberance prominent on the posterior side, right and left preauricular points. So these are the reference points for measuring, whereas the reference for the electrode leads would be mastoids, M1 or M2 on either side. So first we should measure the distance from the nasion to inion. Say for example, if it is 40%, then 10% of it would be 4 centimeters. So from nasion, 4 centimeter in the midline would become FPZ. So this is the first reference point you measure. From there, every reference point comes as 20%, 20%, 20%, and the last one from inion to OZ would be 10%. So all these points are marked on the head of the patients before even connecting the leads. You have to mark with the marker. So this is the first step. First step would be marking all the landmarks from where you should measure. Second step is to measure the distance between nasion and inion on the midline and marking the FPZ, FZ, central. So I forgot to tell you about this. FPZ is frontopolar. Z means that is it is in the midline. FZ is frontally in the midline. CZ is central in the midline. P is parietal in the midline, O is occipital in the midline. So next you should measure from the left preauricular point to the right preauricular point. Say for example, if it is again, say for example, 20 centimeters, then this 10% would be 2 centimeters. So again, like I said earlier, 10-20 is the first step from the landmark would be 10% on either side, and the remaining are all 20%. So the midline marks are all T3, which is temporal, C3 again central, CZ which you have already marked. This is the point which you mark as CZ, the intersection between the horizontal as well as the vertical line. And C4 is on the right side and T4 on the right side as the temporal point. So this is the third step. So first step would be landmarks, second step would be midline markings, that is Z points. Third would be all the horizontal points from left as well as right periauricular point. So then comes this. Don't get scared away because it becomes a little complicated here. So here now we will measure from the point of OZ through T3 to FPZ to T4, which becomes the circumference of the head. So half of it would be on this side and half of it would be on this side. So though it is a 10-20 system, just because it has become half now, so it has become 5% here and 5% on either side of midline. So all the points, like I said, 10, 20 would become 5 and 10 here. So it is 5% from OZ to O1, and O1 to T5 would be 10, and T5 to T3 would be again 10. Then T3 to F7, 10, F7 to FP1 is 10, FP1 to FPZ would be again 5%. So this is how it goes. On other side also the same thing points. Now coming to the fourth step. So are we going to connect on T5, T3? No, we just need the three leads which I told earlier, frontal, central and occipital. We don't need the other leads. This is just for the reference points. So now coming to the occipital, that is O1 is here. From O1 to C3 and C3 to FPZ, you just start a straight line, then divide it into half, which becomes 25, 25, 25%. Say for example, from here till here, say for example, if it is 20, then each distance would be 5 centimeter, 5, 5, 5, 5, which becomes 20 on either side. Now we have found out the C3 and C4. So whatever is in bold here is what you are going to connect. Say for example, here you are going to connect F3, C3 and O1. Same way F4, C4 and O2 are the points you are going to connect in real patients for 1020 system in level 1 PSG. So I hope you have understood the basic points. Now I'll show you a small video about how it goes in real patients where we connect. So now you can see here, this is a somnomedic system where you can see that the number of hours of recording are being given and the recording is started. So I'll show you the video of how to connect it tomorrow. So that today we'll straight away start because it is already connected and kept. The patient is also ready to undergo the sleep study. So this is the video feed where you can see. So we are yet to start the video recording now. The patient is all connected and ready. So this you can see as a typical setup of a level 1 polysomnography where it is similar to home's bedroom. So you can see on the screen. So this is E1, E2 are all EOGs. F4, F3, C4, C3, O2, O1 are all EEG, what we know. M1 and M2 are all reference leads. EMG1 and EMG2 are chin EMGs. Impedance is the resistance to all the flows. It is the total impedance. ECG is lead to ECG. PLM left and right are all leg EMGs. This is the pressure snore sensor, which is also calculated from the nasal cannula. This is thermistor, pressure flow, which is again nasal cannula, pressure transducer. RIP thorax, which means thoracic belt, abdominal belt. This is SpO2 sensor, plethysmography, pulse rate, and position. So these are the leads were all in a level 1 polysomnography. So now once connected and the patient is put on bed, we need to see if there are any sensors that are missing. As you can see here, the SpO2 started coming just now because the sensor was showing some artifacts. And now we will be able to see the saturation coming to 98. So now it has started recording. So this is the pulse rate again started coming, and this is the plethysmography. So here you can see so this 30-second is the total window here. So this 30-second mentioned here is the total 30-second window, as you can see here. So what you're seeing now is the actual window which you should use for scoring. The previous ones were all without references. Now as you can see here, F4 lead, that is the frontal 4 lead, is reference to M1. F3 is reference to M2. C4 to M1, C3 to M2, O2 to M1, O1 to M2, and this is EMG1. These two are all EOGs, that is electroculograms. These 6 are all EEGs, and this one is the chin EMG. So leg EMG, I have not added it here, but you can see, you can add it later. Whenever you want, you can add everything. Patient will definitely have certain doubts, so that's what he's being cleared of. So all the leads are being checked up. Now I'll show you the respiratory channels. So this is the pressure snore. The pressure snore and snore sensor are slightly different. Pressure snore is the one that is sensed from the nasal cannula. This is flow TH is flow thermistor. This is pressure flow, which is nasal pressure cannula. RIP thoracic belt, which means thoracic belt. This is abdominal belt. This is SpO2 sensor. This is the plethysmography, pulse rate, and position. So this is a typical level 3 study or a respiratory polygraphy where you see these things. So patient has not started sleeping, so you cannot score all these events. These are all wrongly scored by the machine, which we can take it off whenever we want. So that's why we say manual scoring is always better than a machine generated one, because machine calculates all this as hypopnea. But we know that the patient has not slept. So there's no point in scoring when the patient is awake. Now let's see if the patient has slept. So the leg EMGs are being fixed as the patient has come with tight pants. So that is the bell which we give to the patient to say if they have any issues, they can call us by ringing the bell. So Now we need to do an important thing which is called biocalibration. So the patient has to be given the instruction. They have to know that it is being told, so that they will do the same thing which we have to check on the sensors. Say for example, we'll ask them to take a deep breath, which will be reflected on the pressure sensor as well as the thermistor, which we have to see whether it is recording correctly. Because this biocalibration step is the most important step, because if some sensor is not working, this is the time which we have to fix it up. Let's now see like how the biocalibration is done. The sleep study is not started till you press lights off button, which means the patient is not allowed to sleep is what it means. Lights off is the time when the recording is actually started. Though the recording is there, it will not be included in the final report. Let me ask them to do the biocalibration. Biocalibration start பண்ணுறீங்களா? Hmm. Okay, so you can see the markers there. Now we'll say the patient to keep their eyes closed, where we have marked it there on the screen. So we know that the patient has closed his eyes. So when we close our eyes, the easy ways which we can see are all alpha. So when they are opened, it becomes beta. So that's what we are checking here. So now the patient's eyes are being moved up and down, where you can see on the REM channel, where you can see it on the REM here, where the patient is moving their eyes. So that is how a REM will be looking at. Now the patient is asked to move the eyes left and right. So you can see them getting reflected on the EOG channel. That is the E1 and M2. E1 and E2, sorry. Where you can see the conjugate movements there. Now the patient is asked to hold breath, where you can see on the leads as hypopnea there. And then the patient will be asked to take deep breaths and long breaths. That also will be reflected on the flow thermistor, pressure flow, as well as thoracic and the abdomen bed. is asked to mimic snoring by vocalizing, where you can see on the chin EMG, you can see movements. And you can also see on the pressure snore sensor, where you can see snoring that is appearing here. Okay. Now the patient is asked to hold breath for 10 seconds to mimic apnea or hypopneas. You can see here, there is flat line here. So the patient is holding his breath, which is not reflected on the flow thermistor or the flow pressure transducer. So this is mimicking apnea. Okay. Now the patient is asked to clench the teeth to check for the EMGs whether they are working or not. So the patient is asked to move their limbs so that the leg EMG can be checked for. So they'll be asked to move right first and then left. They have to dorsiflex their ankle so that the leg EMG is picking up the signal or not will be checked for. So you can see the left PLM and right PLM, which is the leg EMGs. Now the light is still switched on. So as you can see the patient here moving the left lower limb, dorsiflexing the lower limb, which can get reflected on the channels here. You can see the left limb showing limb movements. So this is how a bicalibration is done. So you check each of the sensors, whether they are working properly or not, so that you know that when the patient sleeps also, it records the events properly. So this is a dual base window where this one is an EEG window and simultaneous recordings of respiratory channels can be kept here. So which means this is a 4-minute window. This is a 30-second window. So EEG should be scored in a 30-second window, whereas a respiratory channels can be scored between 2 minutes to 5 minutes. Any time window can be chosen as preferred by the therapist. So like here, you can see a small box moving here, which is the 30-second that is shown here. So the 30-second EEG recording that matches up with this respiratory channel is what this box means. So when you keep moving it, so the box moves to the next epoch. So this 30-second epoch here will be depicted by the respiratory channels with this. So it's a 4-minute window with the 30-second down here is shown. So now the patient is being prepared to start sleeping. So it will be marked with the lights off marker. So that we need to know that this is the time when lights off was done. So that from then is the sleep latency calculated, and the sleep scoring or all the report that comes on a PSG report will be calculated only from here. So the lights are switched off. So this is an infrared camera. So the infrared part is also switched on. Now you can see the patient clearly. So now is the timeline where you have to mark the lights off. So lights off is an important part where you have to define lights off is the point. It comes here. So lights off is done. Now we'll keep seeing the recording so that when the patient sleeps is what we are worried. These are all small alpha waves where you can see. Tomorrow we'll deal about what are the waves and what waves do you see in each stage. So today you would have known about how a 1020 system works and what we connect and what we see on the window on a polysomnography. So as you can see, the patient is well awake, but the machine scores this as N2, which is definitely wrong. And keep scoring it. This is again a wake stage. Patient is still awake. These are all alpha waves which are all prominent on occipital leads. So one artifact that is seen here is the ECG artifact. So this is the heart rate that gets conducted to all the leads because the leads are near some blood vessel, which can be corrected now, but I'm not going into the details of how to correct it because it will disturb the patient's sleep. It can, if it is very much interfering with your scoring, then you can go and correct the lead placements. So this is a slow eye movement. As you can see, there is a small wavy pattern which you can see as a slow eye movement. So this is significant for N1 stage, or the patient is getting into sleep. Patient has not started sleeping yet, but he is slowly moving into transitional stage and then to N1 stage. So this is a hallmark of slow eye movement. So sinusoidal wave where you can see. Patient is turned to on right lateral, and you can see the position also is changed. Supine to right, that's the position sensor. Still the patient has not slept. Still the patient is in wake stage only. These are all wrongly scored by the machine as N2, N1. இதுவா? Start பண்ணலாம். Okay. So let us wait for the patient to sleep. Now let me show you the sensors what we all connected here. So as you can see here on the corner here is the EEG. This is the These are all EEGs. Sorry, these are all EEGs. This is a leg EMG and ECGs. This is the position sensor which will be attached to the thoracic or abdominal belt. This is the snore sensor. And then this is the thermistor. This is the nasal cannula. These are the bells, and this is the SpO2 sensor. So first, let us start with the initial finding of the nasion and inion and marking it with a marker, and then measuring the distance from nasion to inion. Okay, and note it down so that you can find 10% and 20% as and when required. This is again a closer look of the same measurement where you can see the nasion and inion being measured and being marked. Now coming to the second step where you mark the preauricular distance, both right and left preauricular distance. And then whatever is intersecting with the anterior to posterior line becomes the CZ. Now from already we have found out how much is the 10%. So now we mark this is the nasion and this is the next point which is 10%, which becomes FPZ. So it is in the midline. So from there we start to mark with 20%. 10% is already over. And now the EEG leads are being connected. So as I showed, the EEG will be connected. It's always better to connect inside the t-shirt or shirt so that it doesn't affect the patient. So initially the skin is being prepared with a skin prep gel, which is very important because the skin's upper layer is being scraped off and then the low impedance gel is being pasted. So this is very important so that the skin is being prepared properly so that the impedance is as low as possible to pick up EEG signals. So every point where you mark will be prepared with skin prep gel and then only the low impedance gel will be used. This is the midlines OZ point, sorry, or the inion, and from there 10% would become the OZ. The patient which we have connected today has not slept till now. I'm just waiting for him to get into sleep. After using the low impedance gel, we'll fix it with a micropore so that it doesn't fall off. Though saying is very easy, it's actually very difficult for us to connect and fix it up the whole night so that the recordings are perfect. That's why we got backup leads, where if one of the leads fails, you don't need to always go and reconnect it every now and then. You can keep scoring as long as you have got the backup leads that go without any interruptions. So this is how an EEOG is getting connected, where it is on the left side, which is 1 centimeter lateral to the outer canthus and 1 centimeter below, similar to how we connect an EEG. So that is the reference mastoid on the left side. And this is the right sided EOG, where you can see it is 1 centimeter lateral and above to the outer canthus. So as you can see here, this is the EMG's reference point that is connected 2 centimeter above the lower border of the mandible's lower border. So these are the two chin EMGs on either side of midline, 1 centimeter below the border of mandible as well as 1 centimeter lateral to the midline. So that is how chin EMG on the right and left is being connected. So this is the total connection. As you can see, the chin EMGs, EOGs and the EEGs connected, and the wires are being led to the backside. This is the RIP belt. One is thorax and the other one is the abdomen. So it is not to be tight it is not to be too tight or too loose. A simple reference would be just 2 fingers on either side should be easily slipped inside. And the patient also can tell us whether it is too tight or too loose. Too tight or too loose just comes with practice. There is no specific method to do how tight or how loose it should be, but just a simple reference of a 2 fingers that can be slipped in easily would be this. So this is the RIP belts connections, where we connect on either side of the belt, and the main sensor goes to the head box, as you can see on the left corner. Same way the thoracic belts are also being connected to. This is the position sensor as I showed earlier. This is to see whether the patient is supine or lateral positions. So that is the snow sensor, which is being thyroid cartilage is being palpated, and then onto either side of thyroid cartilage, snow sensor is being put. Just a simple microphone which picks up snow sounds, and that is the nasal cannula, which picks up nasal pressure transducer signals. Just like as we connect a nasal cannula in wards, it's being connected. This is the thermistor, which is connected just like a nasal cannula. And the small loop that is coming below is to pick up oral breathing or mouth breathing when the patient opens his mouth. This nasal sensors may not pick, so the oral sensor might pick up, just to tell us whether the patient is breathing or not, whether there is apnea or an hypopnea or not. This is just to fix the cannula's wires so that it doesn't slip away, because during night the patient will be moving to left or right, so it shouldn't slip away. This is the SpO2 sensor. So the SpO2 sensor is connected, and this is how the connections go. So these are the two things which we already told, which is the 1020 gel is the conductive paste and the new prep gel is the skin prep gel to prepare the outer layer of skin so that any dead cells or anything that can be scraped off. First, new prep gel will be used. Once it is piped off, 1020 gel will be used for fixing the leads along with the micropore. This is just to show you how a mask is also fixed. So the nasal thermistor is taken off and the nasal cannula. Instead of that, a mask is being fixed to do a overnight in-lab titration. So all the other leads will be similar to what we connect in a level 1 polysomnography, except the nasal thermistor and the nasal pressure transducer. The mask will be fixed, which senses the flow as well as the apneas and hypopneas. Whether the connecting tube is connected and it is fixed to the mask. The other end is connected to the pack machine. So how did we connect the mask is by checking for the size, whether it is small, medium, or large, based on the mask company's recommendations. So each and every company will have different recommendations to size. This is for the oronasal mask, where small, medium, and large can be seen based on the patient's facial structure. Each of the mask is tried to fit in. So this is just an overview of how did we connect it. So as you can see here, these are all slow waves where you can see this is an alpha wave and this is an slow wave. Slow wave means this is 1 second window where you can see one, two, or three peaks of waves, which means the frequency is only three, which becomes a slow wave. Whereas here it's an alpha wave where you can see many such waves like the frequency of more than 8 to 10, which becomes an alpha wave. So the slowly patient is transitioning into sleep now. So and the events have already started appearing here. So as you can see here, the flow is definitely reduced here along with desaturation here. Same way here, you can see the patient's flow is reduced here and the duration is at least 10 seconds. The duration is around 11 seconds. The desaturation here, which becomes a hypopnea. In a 4-minute window, you can see almost here 1, 2, 3, 4, and maybe 5th event. The pressure snore is also trying to pick up snores here. 1, 2, 3. These are all snore that is being picked up. You want to see it clearly? See, the patient has started snoring. These are all patient's coughing movements, and the patient has become supine now. So let's wait for another 5 minutes and then see if he's sleeping. So tomorrow we'll see about basic EEG waves and how to identify stages. And again tomorrow there will be another demo where you can see similar to today what like how the waves are being formed and how do we start scoring. So any doubts you can put it in the chat box or you can put it in the WhatsApp group. Will be clarified soon in the class. Thank you.